I'm really excited to have my guest, Dr. Alexandra Sowa, on the podcast today. We're going to be talking all about GLP-1s. You know that as Ozempic or Wegovy. We'll talk about obesity, what causes obesity, what treatments are available for it. I'm super interested to have this conversation today. I've been in this field of fitness, wellness, and nutrition for the better part of 17 years now. And I know it is far more nuanced than just someone not being able to stick to an exercise or eating routine. And I just want to dive deep into that because I think it's so important that we understand the background behind obesity. And I think so many people, when I look on social media, just don't have compassion for people in this circumstance. We think, oh, if you just did X, Y, and Z a little bit more, you wouldn't have this issue. I just don't think that's the case. I just don't think that's the whole story. And I just want to ask Dr. Sowa about her research on this and her thoughts. Of course, she's written the book, The Ozempic Revolution, which is what we're in the middle of right now. So it'll be really interesting to talk to her about this today. Dr. Alexandra is a dual board certified physician in internal and obesity medicine, founder of Sowell, and of course, author of the groundbreaking book, The Ozempic Revolution. With over a decade of experience, Dr. Sowa has become a leading voice in metabolic health, specializing in GLP-1 medications and their transformative role in tackling obesity and chronic illness. Through Sowell, Dr. Sowa extends her reach beyond the clinic, offering innovative telehealth services, metabolic and GLP-1 support products, and resources that reflect her philosophy of care, both holistic and evidence-based. This is going to be a good conversation. Let's welcome Dr. Sowa. I've been so looking forward to this conversation. As a lot of you know, my background is in psychology. And so when we help people at Move Daily Fitness, we're constantly looking at the whole person through the lens of psychology. We're looking at not just the how do we lose weight, how do we get fit, but what is stopping us? What are the barriers, the boundaries that we've put up? Why can't we lose weight? And as I was just speaking to Dr. Sowa right before the podcast started, this is her element as well. She doesn't want to just give a prescription and say, here you go, out the door, good luck. But it's really about exploring that why. So thank you so much for joining us, Dr. Sowa.
Thank you so much for having me. I'm really happy to be here.
Absolutely. So was this always the thing that you studied in medicine? Was this how you got into medicine, always looking at weight loss, or how did this all start for you?
No. So I always knew that I wanted to be a preventive doctor and I wanted to help people stay healthy as long as possible. But it really wasn't a specialty when I started off. And I pursued internal medicine at NYU and had excellent training, but the majority of our education, as it is in the United States, is on end of disease management. And I was like, hold on, we're telling all of our patients to lose weight, but weight loss is hard. I don't know if you've tried it, like I'm telling my preceptors this, I don't know if you've tried it, like this is really tricky. I know at this point that it's not about exercise, just food. It's more complex than that, not calories in, calories out. And as I was really exploring and looking for where I was going to fit into medicine, I found the nascent, very early field of something called obesity and metabolic health medicine. And I was so fortunate to get early exposure. And once I discovered that we had tools in medicine and there was a comprehensive specialty being developed to help people that was beyond just surgery, which we had in their toolkit for a while, but I knew I wasn't a surgeon. Once I found this, there was no looking back. And I talk about this in the book, The Ozempic Revolution, but my motivation goes back to childhood, talking about weight and dieting and food was a big part of how I grew up. Now, I had a really lovely childhood and I actually have a very comfortable relationship with food in my body. But my poor grandmothers on both sides really, really struggled with their weight, truly struggled with their weight and they did everything and they were put on every diet under the sun. I mean, the craziest things. My grandmother in the 1950s was put on a watermelon only diet when she was pregnant
Oh,
with her
that's it.
twins.
Oh my goodness, that's terrible.
And
Cabbage
she
soup
actually
diet.
delivered those babies. She told me thinner than when she started, but then her weight, of course, now I know what happened. Her weight just exploded because she just destroyed her metabolism.
Mm.
And my grandmothers, they'd be talking about recommitting to Weight Watchers and the new point system and tracking their steps and doing this and doing that and eating low fat and then eating no meat. I mean, I think there was a period of time when they were like doing no meat and no sugar. It was insane. And I remember thinking, this is not right. And I don't want to be this way, but what is the path forward? Because these are clearly some of my genetics. And then unfortunately, both of my grandmothers did pass from obesity related complications. And I just think that I brought that early on into my career was this intimate understanding that weight is not about willpower, because darn did my grandmothers try. There was something much more complex about it. And I think I'm getting the chills talking about it because I think about them often. And they deserved now what I can give my patients. And so I do bring a real, as we were talking, a real emotional understanding to this, that everybody has a very complicated story when it comes to their weight. And it's not just about, getting a shot. So I still had to become an obesity medicine doctor within the confines of traditional medicine, right? We have boards to pass, we have things to study. But even in my specialty, I realized, there's a lot of talk about drugs. What else do my patients need? What do they need in this comprehensive manner? Okay, they need to learn how to eat. And not on a diet, but they really need to have a good understanding of how to nourish themselves. They need to learn how to move. They need to learn how to rewire habits that maybe they tried before, but then put them into a super negative headspace and felt oppressive. But what are healthy habits that can help us move forward? How do we learn how to think about this in a new way that feels fulfilling and not oppressive? And so I took the first part of my career post training, really developing this method to help all of my patients and pull them along. So getting to this place wasn't linear. And a lot of medical students ask me, how do you do this? And I'm like, okay, there's a lot of reading and there's a lot of learning and there's a lot of listening ahead of you. You really have to listen to what your patients have to tell you. So it's been an exciting field. And I've been really fortunate to be able to kind of create my own path in helping people.
I absolutely love that you're including both of those things. I think that's just, is that a common thing that a physician would look at the whole person, that they would look at the psychological component along with just the physiological component? I don't know. Is it
Is it
common?
common? I think most people go into the health field because they do want to truly help people. But I think our current systems have made it so that there's 15 minutes in a visit and it takes
Yeah.
3 months to see them again. And so there's only so much that many doctors can give. Um, I think I have a particularly deep pull to do this practice holistically that I don't think a lot others see. And that was one of my biggest motivations for writing the book, The Ozempic Revolution, was I truly think these new medications are revolutionary. I think they're a great modern miracle, but I think we need to be thinking about this holistically. So I wrote the framework that I developed for people who are talking about these medications with their doctors, thinking about it or on it and are feeling like, I don't know, do I really want to be on a medication for life? Or what do I do? How do I eat? So I wrote this for them so that I could translate it, because I've even been getting the feedback since this book came out a few weeks ago from a lot of doctors who are like, this is so exciting. If I had all the time, I would tell them these things, but I don't. And so instead, I'm just going to give them your book,
Yeah.
And so that's such great feedback to hear.
Yeah. Take us through a framework of what it would look like if someone came to see you. What is the starting conversation that you would have with someone to begin to sort of open up Pandora's box and see
Yes.
what some of those precipitating events or experiences or mindsets that need that shift?
I think the first conversation I have with patients is, what are your goals? I
Hmm.
really want to hear that from somebody first. And I don't want to tell them what my goals are. I want to hear what their goals are because that truly is the most motivating. One of the things I ask all of my patients to do, if their goal is weight loss, I will say, why? Let's
Yeah.
really dig deep and meditate on this and think about why are we doing this? And I ask people to come up with about 3 things. And one of those things is allowed to be vanity, something rooted in vanity. I want to, look good in my dress for my son's
Sure.
wedding. But I found that that actually isn't motivating at all long term. It's not, those patients are not fulfilled and they're not the happiest. And the weight loss won't be long lasting. And so, what we need to find is something much deeper. I want to get on the ground and play with my grandkids. I want to be able to walk up the subway steps without huffing and puffing. I don't want to have the same fate as my grandmothers ahead of me. I really want to approach my health and my second half of my life differently. Those are motivating. So if someone comes to me and says, and going back to the question of what do I say, if someone says to me, I want to be skinny, we're going to have a deeper conversation because to me, we're not in the right framework place, frame of mind. We're not in the right place. And this is probably might not be the right path for you. So once we get beyond that, I also do a deeper dive into what's going on.
Hmm.
So one of the things that I think is problematic about what's happening with these medications is that people are able to get them without any metabolic workup. And I look at a pretty big set of labs. Nothing true out of the ordinary, but I want people to know, again, why are we doing this? Where are we with our metabolic health? Do we have early insulin resistance? Are we on the path to type 2 diabetes, even if it's very early? And generally, I do find that in about 80% of patients who are struggling to lose weight, we will find signs of early insulin resistance.
Hmm.
I'm a big proponent of looking for that because it gives people a really good lens to look through to motivate on how to eat right, how to exercise. It's not all about weight loss, it's about health and how do we make our blood sugar optimal. I'll look at the thyroid. I look at a select few vitamins. I will look at if people tell me they're super fatigued. I like to look at iron stores and ferritin, and I look for elements of inflammation. So we go through that. And again, that helps us establish our why. And then we look at all of our options together, and we really need to learn where people are in their life. Are they thinking about having their first child in the next 2 years? Are they done having children? And because that is part of the conversation of who these medications are appropriate for. Are they someone who really is fearful of medications and is very worried about the possibility of needing to stay on a medication to continue the benefits of it? So we really just need to understand all of this so we can set expectations. One of the other things that I really like to do is go back. Tell me about your weight history. And they'll say, starting from when? And I'll say, starting from as soon as you thought about it. For some people, that's as early as 5 years of age. Some people, it's middle school. Some people, it's just in the last few years. That also helps inform me on the work that we'll need to do together and also helps us set expectations of kind of a more appropriate treatment plan. Somebody who has put on weight in 3 years is very different than someone who's been carrying significant excess weight from age 5, right? Do we need to look at an underlying genetic component? Is there a particular medication that's right for you? Maybe if there was just a life event or another medication that put on the weight, we might be able to actually use this medication and change habits to very quickly take it off. And maybe you are the patient, the 10% of patients, 5 to 10% of patients who are able to come off of this medication long-term and not need it. So, I just think it takes some time. I lay out the framework in the book for patients because look, it just even took me like 5 minutes to tell you about my simple approach, right? And so if you can imagine in a doctor's visit, it can get a little complex.
Very interesting about looking at their history too. I think that is so wise because yes, was an event that triggered the eating or the overeating or the eating addiction? Was it a genetic component? Was it something physiological inside? Like, I don't know much about the physiological inside, but like a hormone,
Right. Right.
regulation,
Were
whatever.
you diagnosed with hypothyroidism when you were
Right.
15? Or was there, often people can say, hey, there was a tipping point, or I was really sad my freshman year of college, or, I became a lawyer and was kind of miserable and I sat at a desk all day and then my only reprieve was coming home and eating. There's something that generally people can say, and it's so good to tap into that because that emotional connection, or maybe it's not even an emotional connection, it was just an event. It's really good to know because we need to kind of take ownership back of that. I also think it's important to ask about weight history because many people, the weight history is an up and down, up and down, up and down. It's that yo-yo, right? The thing that I am so anti is yo-yo dieting, and I don't want these medications to be another tool for anti-diet, for yo-yo dieting. And I think when people have gone up and down, there is another set of challenges that I lay out in the book where your brain is constantly telling you that this will never work because it has never worked in the past. And there have been periods of time where you think it's working and then it doesn't. And that is something I really have to prepare people to manage their own brain, because in this scenario, these medications are different and it will work. It will work. But only if you believe in it and keep doing the foundational work.
Yeah. So mindset is really crucial when it comes to weight loss, is what you're saying.
I think so. I know you agree with me on that, but it really is. And I have learned cognitive behavioral therapy techniques in my practice, and I embrace them as a really effective way for people to stay on top of their own negative thoughts and reactions on their own. I think it sets forth such a simple framework that you are able to work in very small ways on your own at home. Now, many of my patients throughout their journey will need to be referred to a therapist, a psychiatrist for something that we can't manage together, and they certainly can't manage on their own. But I do think mindset is just so critical. It is the thing that's overlooked in the weight loss journey, especially the GLP-1 weight loss journey, because at first, when you go on these medications, your food noise and your interest in food can be so quieted that you feel such great relief. But the thing is, at about 5 to 12 months on any given dose of these medications, science tells us that that food noise, hunger, will start to come back. And that's normal and that's natural, but that can incite panic, especially if people are not working on controlling their brain. And they will spiral very quickly that the medication isn't working, that they're one of the people that they heard about that's a non-responder. And then they'll go back to all the bad habits, or worse, they'll just stop the medication because they've convinced themselves that this isn't working and wasn't worth it. And we can always stop a medication. That's not what I'm saying, but it's just the idea of just like catastrophizing the whole weight loss process and then further cementing another trauma in your soul that this weight loss attempt didn't work either. So I think learning skills to identify negative thoughts and then learn how to rewrite those negative thoughts into a new behavioral script is very helpful. I actually give those scripts to patients in the book, because after treating thousands of people think they're super individual in these thoughts, but the fact is nearly every single person will have some of these same conversations. So I kind of took my top 20 that I hear over and over again. I'm like, this is how we've worked on this. This is how you can work on it too. And of course, you're going to bring your own history to it, but mindset is the number one thing. And I'm always telling my patients who are years out from their big weight loss, I'm like, okay, remember, it could happen any day that your brain starts to tell you that, you should just stop now. You should give up and we should go back. And so people in my practice know that I talk about something called red flags. And the red flags are when you stop doing the things that got you to this place. And you need to identify those things. And when we get to the end of weight loss and we move into maintenance, I'll say, okay, what are you doing right now? And they'll tell me, okay, I'm embracing the Sowell. I call the method the Sowell method. I'm embracing those foundational habits, like stepping on the scale. And maybe we can talk a little bit more about that, because that's very triggering for people. But people learn to step on the scale regularly as a tool, and they're not very emotional about it. But if they start skipping and they start to get emotional about it, that's just an identity. It's a red flag. And then they know, oops, I got to move up my appointment with Dr. Sowa. I got to do some work. I've got to pull out my journal. What's going on? Let me identify it. Or you've been someone who's been taking your lunch to work for years it worked for you. And then you had a stressful event and then just started ordering, the fast food. That's a
Mhm.
red flag. Something changed. So I think just being aware that it's not oppressive effort, but there's just some effort. And then when something changes, we have to be on the lookout for that.
Those neural pathways of that self-talk, it just runs so deep. And it could have developed in childhood and it carries with that, carries on into adulthood. And I think that's exactly what you said when we need to be cognizant that it's happening inside of us. We need to recognize the patterns or what is triggering these thought processes. And then I think for a lot of us, whether we have an addiction to food or anything else, working with ourselves and understanding those stories that we tell ourselves and what's going on inside, what triggers us, why we're reactive, I think that is so crucial. I want to go back to the food noise. Could
Yeah.
you go into depth and just explain to us, for those of us who perhaps have not had food noise, what is it? How do we recognize that? And why is it quieted by the GLP-1 initially, and then why does it come back?
Yeah. So maybe just really quickly how GLP-1 medications work.
Yeah, let's
So
talk about
they
that.
so they mimic a hormone that naturally occurs in our body. That hormone, though, is very short lasting. And in an optimally lean body, just like a body that has kind of a normal balance, it works. The problem is it's not very effective as an anti-hunger satiety hormone when we start putting on weight. And that's where this synthetic version of the hormone has been so effective. It works at the level of thousands of times stronger than what natively occurs in our body. And it's not just an appetite suppressant. It doesn't just work on the level of food noise, which we'll talk a lot about. It works on the brain. And you were talking about the hormonal pathways that we establish in thought and regulation. Those same pathways are affected by what we've eaten in our lives. And a lot of hyperpalatable food can get into our brain and actually ruin those pathways. And
Mm.
so I argue that much of weight gain is actually a distortion between the brain and the hormones in the rest of our body. And that's not just something I've come up with. That truly is what science says. It's neurohormonal dysregulation. So it works on the level of the brain to just quiet our thinking, our constant thinking about food, and to tell our brain we're full. You don't have to keep going. Then it works at the level of the gut, where really it slows down our digestive tract. And so food will sit in our stomach a lot longer. And that allows our stomach and our GI tract to signal fullness and satiety hormones, say, we're not hungry for right now. And then the third way that it really works is on the level of the pancreas, and it regulates blood sugar. We talked at the very beginning that the majority of people who have trouble taking off weight and just keep putting on weight have insulin resistance. And this drug targets the pancreas to make our body very efficient at secreting insulin, grabbing up glucose right away and stabilizing blood sugar. And when that happens, our body is able to tap into its own fat stores and we lose weight. GLP-1 receptors are all over the body. And this is why we see such tremendous health benefits from these medications that are independent of weight loss. So
Right.
our cardiac protection, brain protection, kidney protection, it improves sleep apnea. We've got even lowered inflammation all over the body. It's pretty remarkable. And that's because our whole body responds to the hormone. So it's a pretty neat drug. It really is. And the food noise component is not something that's scientific. It is something that has been coined by the internet. And it describes it pretty well, which is when you start this medication, because of these three pathways working in this like perfect agreement, you just quiet your thinking about food for potentially the first time in your life. And it can be very, very freeing. For some, it can be a little scary. And the goal is not, I always tell my patients, the goal is to not eat. We want to eat, and we actually do want to make sure you have some level of hunger and awareness of it. So I have people working on that before they start these medications. I have them tracking their food, tracking their hunger, trying to tap into the sense of, am I hungry?
Right.
Am I full? because once you start these meds, that can go away. And it can be really hard for me to say, are you truly hungry? I'm like,
Right.
I don't know. I don't know. I'm like, did you ever feel that way before? I don't know. I can't think of it. So it is very dramatic. I write about case studies in the book, and I have a patient who super effective C-suite, person out in the world. And yet food controlled her. She ate it. She had a good relationship with it, but told me she constantly was thinking about her next meal and what she should or shouldn't be eating for health. And when we went on a very low dose of this medication, she told me I gave her 4 hours of her day back. And I thought she was joking. And she said, no, I think I have about 4 more hours to be present with my kids, to be creative, to be more focused at work instead of constantly thinking about food noise. Now, that's pretty dramatic. For most people, it's just that they're not constantly thinking about a snack. And if they go into the kitchen, they're like, I don't want anything. And that can be a totally new sensation. So it is dramatic, but it's not the only way that this drug works. And I did mention people need to be aware that the hunger will come back. The weight won't. It doesn't mean the med's not working, but at some point your body will start to say, you do need some hunger. like this is an important feeling, and it does come back, and that is not the worst thing in the world.
Yeah, that's very interesting. Who would you say? I mean, a lot of people obviously are struggling with obesity and struggling with weight. Who is a GLP-1 for?
So the FDA makes it quite clear about who these medications are for, and the drug companies have very clear indications. But I will say this is changing. This is changing and expanding. So by the guidelines, this is a BMI criteria when it comes to weight loss. So some GLP-1s are approved for type 2 diabetes management. And then the ones for weight loss say they're appropriate for patients with a BMI greater than 30 or a BMI greater than 27 with something called a comorbidity. This reasoning is flawed a little bit. It's great for just general population. And I should clarify, comorbidity means like another health condition that's related to weight, or it could be improved by weight. So the list is very big, and I can usually find one. High blood pressure, insulin resistance, joint pain, back pain, things like that. Mm-hmm. So the reason it's flawed is that BMI just takes into account your height and your weight and doesn't look at the body composition. And it's also not taking into account this concept of really, it really comes down to body composition, but I'll give you an example. So a patient who was very lean their whole life, thin, and then something happened, and then they put on, let's say 30 to 40 pounds, and their body fat percentage skyrocketed because that hormonal weight gain was all fat and no muscle. But their BMI criteria doesn't quite meet the cutoff. Should we deny that person the ability to take that weight off? Probably not. So I do think that we should have clear guidelines, but then each patient is nuanced. Maybe we can talk a little bit about who the drug is not for.
Yeah.
Because I think that maybe is a more interesting conversation right now.
Sure. Well, and I'm just thinking too, when women go into menopause, there is this drop in estrogen, which affects so many things, of course. And we see an increase in belly fat for a lot of women in this age. Have you seen an influx of women in their 40s, 50s, 60s taking this medication? And should it be for the person? Like, it's just, when I look at it, I think who is exactly going to benefit the most from taking it versus maybe the person, who doesn't necessarily have this food noise or a lot of the psychological or physiological issues that have led to obesity, but it's rather maybe just some lifestyle shifts that they could benefit from. Like who would benefit from it greater, I suppose, or should a subset of people just be focused on nutrition and exercise and some habit formation versus anyone could benefit from this go on it, learn your different lifestyle shifts and habit formation while on it, and that's going to get you there faster. Do you know what I mean? Like,
Mhm.
it's like, yeah,
I think it's, it comes back to that idea of what I ask patients what their goals are and their weight history. I think a lot of times people can tell you, listen, I trust my patients. I think a lot of doctors
yeah,
don't actually believe patients when they say, I've been doing all the things. I strength train, I eat
yeah,
well, I'm doing it. Like, I believe you. I believe you. Weight loss is hard. And if someone's
yeah,
coming and saying, look, I'm doing all the things and nothing is moving the needle, and okay, maybe my blood pressure isn't up yet, but I have a very strong family history of heart disease and stroke, and I think I'm ready for medication. Well, then I believe that person, right? And also for the person who maybe is like, listen, I have tried to eat well my whole life, but I'll be honest with you, I have a very hard time with it. I need something to potentially help me eat better. And then I believe that person too. I will, of course, teach all of the nutritional foundations. But the thing is, most people who don't eat well or could optimize their diet or no, like have excess weight, they know that. They know that.
yeah,
And if they
of
could
course.
have changed it on their own, they would have.
All right.
Biology is very, very strong. And I will often say that this medication gives people willpower. It gives them time and space and ability to make the changes that they've thought about or maybe tried for a day and then gave up after a day. But it allows them the freedom to actually embrace these things. Something fascinating about these medications is that not only do they quiet food noise, but they actually change the biology of what our body wants to eat. So it's at the level of the brain, but it's also at the level of our taste buds. Truly, our
Really?
taste buds change on these medications.
Mm.
And I will have patients, they are just so blown away. They're like, I crave broccoli. I'm a person who now craves broccoli. Look at me. And for all those years, they thought that there was something wrong with them and they weren't doing it right. But something about their neurohormonal dysregulation had made it so that they truly only wanted the hyper palatable foods that are too easy for us in this Western environment. And then after 40 years of eating one way, 60 years of eating one way, they're like, I actually want shrimp. I want fish. I want chicken. I want the vegetables. It's amazing. And so we're not kind of giving that part of the conversation enough credit. And people are shopping differently. The big conglomerates are having to change where they're putting their energy and the shelves, what they're putting on the shelves. And I imagine a world with these medications, if we can be very optimistic, that they can really help shape a whole generational change shift where not only are we eating differently in our homes and we're cooking differently for our kids, but we're shopping differently and we're forcing grocery stores to carry different things on their shelves and less processed foods. And, just I think this on an individual level, this has like a collective ability to potentially really help us reset and get back to some more of the basics, because it is not just about eating less or not thinking about food. It's actually like a whole mindset shift. Geez. It's all about a whole mindset shift. And,
Yeah.
people then, once they start losing weight, they're like, I got more energy. I think I can actually do that challenge at the gym that I've signed up for the past 15 years every January. But now I'm going to do it.
Right.
Like, I can do Pilates now. I can do that. I'm going to go out for walks with my neighbors. And so again, it's kind of like there is something that's not just individual about what's happening with our new conversation around weight loss and these medications. It has the potential to be very community and world oriented.
Is there something going on with our dopamine system when with these drugs? Is there a quietening of that system? You said we, previous maybe to the drugs, we crave hyperpalatable foods, right?
Mhm.
Which give us a huge, when we think about that, anticipate that taste in our mouth, that good feeling, the joy in our mouth that can flood us with dopamine. And then we chase that with another cookie or another hyperpalatable thing. And now you're saying a lot of people find that they're craving healthier items. Is it because there's a squashing of the dopamine system in
That's
involved
part of
here?
it. It's part of
Okay.
it. So there's a part of our brain that craves things.
Yeah.
And this is the same part of the brain that's affected by alcohol addiction, drug addiction, food addiction, shopping addiction, sex addiction. It's
Yeah.
all in this reward center.
Right.
And we know that a lot of the foods and behaviors in our Western world have damaged that part of the brain and independent of even the reward part. So we have like two things going on. We have a part of our brain that gets damaged and then creates actually something called leptin resistance, where your body doesn't respond to a hormone that's supposed to help regulate weight. And so that first thing happens. And then, as you're talking about, this dopamine hit that you get with all of these things. And for some people, they can regulate it and say, okay, no more. Then some people, we know they can't. And then we look at alcoholism like a disease. We think of drug addiction like a disease. And same thing when it comes to food. And so, yes, on these medications, we get less of that
Mm.
reward hit. And we can see this on functional MRI. We also, very, very interestingly, are now studying GLP-1 medications in the treatment of alcohol and opioid and drug addiction.
Really? That's
Yes,
exciting.
I talk about this in the book because it really goes to show how kind of globally, systemically in our body, this is working. It's actually quite effective. And I have many patients in my program who have struggled with addiction in the past. And when you have an addiction, you generally tend to transfer that addiction to another, and that can often come in the form of food.
Sure.
Interestingly, in the reverse, with when it comes to bariatric surgery, after bariatric surgery, you take away a patient's ability to eat food as much and get that dopamine hit. There's a
Right.
higher incidence of alcoholism post
Yeah.
bariatric surgery.
Right.
So, but we're not seeing that transfer addiction with GLP-1 medications. So
Well,
it's almost like it quiets everything.
yeah, no doubt people with food addiction would, I'm sure there was a lot of people who also concurrently had an alcohol addiction or, other ones as well. And you probably saw that. You probably saw everything was quieted, right?
Right.
So that's so cool that that's
It is.
happening. You were just saying before, maybe I could tell you who it's not for. Let's go back
Yeah.
to that. And I'd love to hear that because there is a lot of people. I mean, this is this conversation on social, right? My friend is on it. Someone just told me the other day too, their friend is on it. One really should be on it. One is on it because her friend's on it and it's working for her and possibly shouldn't be. And so, yes, let's talk about who it might not be wise for.
So, kind of high clinical level, we screen people for a history of MEN type 2 endocrine cancers or
Okay.
medullary thyroid cancers. So, if you have that in your family, we really haven't seen any problems in humans, but there's a theoretical risk in rodent populations. So, we just avoid. It's very, very, very rare, but I should just say that up at the top.
Sure.
I actually have never had a patient who I could not use this medication in for that reason. That's how rare it is. Um, the second subset of people clinically, we can't use this while pregnant or breastfeeding. And so that's an
Okay.
actually interesting conversation we can get deeper into.
Yeah.
But I think more holistically, the person that I don't want to use this medication on is someone who is looking at this as a method for thinness, who
Right.
values thinness, not health, who can't give me a reason, a motivating why that's rooted in health.
Mm.
I also think we have to be very careful in patients who have a complicated eating disorder history. Now, that is not to say if you have a history of an eating disorder, you're not a candidate for these medications. We have to be extra careful.
Sure.
And then I think the other person that I really need to think of this as right for you is who says to me, I am not a medication person and I will not be on this long term. This is a quick fix. I just want to do this for something in the near future, and then that's it. I have, if you can't tell, I really do like to have informed, long discussions with people. And I have
That's
a long
great.
discussion with my patient always about the fact is these medications are indicated for long term, potentially forever use. And you need to understand that we're replacing a hormone that has gone deficient and rogue. And if we give you that synthetic hormone, we can't anticipate that you will be able to maintain all of the health changes and the weight loss when we take that synthetic hormone away.
Sure. Which is what
That's
we've
not just
seen, right?
exactly. And I don't want to precipitate yo-yo diet culture, because if
Sure.
you want to go off of this in 3 months and you lost 30 pounds and you're going to put on 40 pounds, I don't want to be part of that. Now, there are
Fair.
5 to 10% of people who can come off this medication, and I make a good case for that in the book. I lay that out. People who put on
Okay.
weight quickly, people who really changed lifestyle habits, and people who probably potentially have a genetics that allows them to maintain leanness, and people who really focus on strength training and food. So it's not to say you can't do it, but I think there's a whole culture right now on social media of saying, well, I'll just do this for right now, or follow me and I'll show you how to get off your shot. I'm like, oh gosh.
Really? You'd say
Um,
that? Goodness.
yeah. And so we have to make sure that this is something that is mentally, emotionally, like philosophically and financially viable. And that's a big, big problem, especially in the United States, unfortunately, where insurance companies at this point in time are allowed to play games with people. They'll provide coverage and then they won't provide coverage. Our drugs out of pocket are very, very expensive. And I'm hopeful in the next 24 months, I see a lot of good potential things happening between drug reform, government involvement, and insurance company reform that will hopefully change this conversation. But I really need people to know that if insurance drops it, we need to make sure that this can be some part of your budget. And I hate having that conversation, but it is true. It's important right now for us in the United States. Our cost of these medications is about 10 times higher than it is in Europe.
Wow.
So,
So so the lion's share of people will not be going off these medications then. Is that what you're
mhm, mhm,
saying? That it's like
yeah,
you go on it and this is what you do. You're like a type 1 diabetic, you'll be taking insulin. This is how you manage this disease.
exactly. And we really don't know. I mean, I can sometimes tell people, I think you're going to be patient that I can be on a low dose and take off. You're given your history and you're just where you are in your life right now. But we really don't know. And I will tell you, the majority of people who come to me who say, I'd really like to get off of this. And this
Mhm.
really is my goal. And I'm in it for the right reasons, but I'm going to try my best to get off. And I say, okay, but understand that that might not be able to happen. Those are the same patients who at about 6 month mark are like, please, Dr. So I know I told you once I wanted to be off of it, but I just truly love the way that I feel on this. Don't take it away. I'm like, I won't, but it's interesting how that shift happens. But yes,
Yeah.
people need to understand that the vast majority of people will need this as a chronic disease management tool. And we do need to look at it like any other medication that we use to treat a chronic disease.
Is there any side effects to going off and then coming back on?
Yes. So really it's that yo-yo dieting disaster that I talk about in the book. So every time we lose weight and then we start to put on weight, we tend to put on more weight and we further ruin that hormone dysregulation. So we know that people, even through calorie restriction and exercise alone, who lose weight, and then you start to regain because all of the biology works against you and wants you to get back up to that high set point. When you get back up to that starting weight, your basal metabolic rate is significantly lowered and your fat mass is higher. And that leads to worsening disease. And so I often counsel my patients who are, have children at home still, especially girls. I'll say the best gift you can give to your children is to say, do not try to lose 5 pounds. Do not try to be thinner. This is probably the best, healthiest version of your body. All I want you to do is make it strong. And I want
Yes.
you to work on staying where you are, because starting to get into that just 5 pounds, just a little
Yeah.
skinnier, right? I mean, I think that triggers so much in all of us. I remember back from being very young and thinking that way.
Mhm. Yeah.
Don't, don't, because every time you start that, even in a young age, it sets off a firestorm of hormonal dysregulation and sets you up for a lifetime of doing that up and down. And so
Hmm.
that really is the biggest risk coming off of these medications. Now, of course, if you're also using it for blood sugar control, even if your blood sugar is perfectly controlling these medications, if you take it away, we can start to see significant dysregulation come back. These medications will help heal beta cells at the level of the pancreas where we make insulin. So sometimes you can be a lot better off coming off of these medications are able to come down. But if you were to stop it, you really need to look out for that. The other thing that I have found, and and I've actually yet to find a clinical study that shows this. I think it will have some soon. But if you stop the medication and then you regain weight, and you decide, okay, well, I'm ready to go back on it again, it might not work as well.
Mm.
And it's for the reasons that we kind of laid out with yo-yo
Mhm.
dieting, which is your hormones are further dysregulated. Your body has already seen this medication once, and it's going to
Sure.
be trying to be a little bit smarter. Like it's kind of like, I'm not going to make it as easy for you to lose weight this time. And again, body fat composition can sometimes work, be altered so it works against us. So it is something that people need to understand, that this really is something we need to look at and figure out if this is something we can be on longer term.
What do you think is going on when I just saw this lady on it was a younger girl. It was a TikTok or a reel, whatever. She was running and she was just railing on anyone taking a GLP-1 because they're not doing the hard work, they're not putting in the time, they're taking the easy way out. I mean, we see this all the
Yeah.
time. And really, I think what it was like when I was watching it and observing her, I'm thinking, you're angry or you're jealous. You think that they're getting an easy ride, and you put in all this work to get X, Y, and Z, and you're not, you don't have a before and after picture. Like I don't know, there's a lot going on there. There's a lot of pent up energy for people who are already lean or fit, and then they're looking at people trying to take the easy way out. I don't think it's that at all. I mean, I feel so thrilled for people who struggle with obesity that this is a solution, but it is a really fired up for sure for people thinking, that this is an easy way out.
How do I feel about it? If you're not watching us on YouTube, I have had many eye rolls even as you're describing this. It makes me so angry.
Yeah.
It's it's weight bias. It's weight bias and a false sense of moral superiority that you are one of the lucky few whose genetics worked with your right environment and the food sources you had access to,
Yeah.
and your life has been different than the
Yes.
person next to you, potentially in the same exact scenario. Remember, I am part of a new age of weight loss, which is very exciting, which is not like in diet culture or moral failings. And I am promoting that. So sometimes I live in this nice little bubble. But up until very recently, so much of industry was focused on selling you the next diet, selling you your failings, come do this thing at the gym, or you're not working out hard enough, or you're not eating well enough, or do this or restrict this. And I think it's really threatened our like fabric really as a country, where people thought that they were doing something right because they had leanness and muscle and thinness, and that everyone else was doing it wrong, and we were going to sell you something. And so I think it's just really disrupting what people thought that they had figured out. But really, I think it's just leveling the playing field, and you can keep doing you. I don't need to come for you. I'm not going to insult you for what you're doing, but please don't
Sure.
insult the people whose life this is transforming. And we talked a lot about the mindset that's important, and the cognitive behavioral therapy tools that I think are very important to take along with you in a GLP-1 weight loss journey.
Mhm.
It's for reasons like that. You're going to see something 6 months, 2 years, 5 years in your journey like that. And on some given day, that will trigger you, and it will start to
Sure.
tell you that you should believe that again, because some small part of your body still holds on to that belief. So I think we have to be on high alert for the jerks. I can't come up with a more sophisticated word than that, but the jerks who want to tell you that.
Yeah.
I get worried right now. There's a political movement that is insinuating that we can fix obesity, the disease of obesity, by prevention only. And I think we're getting a little confused in this conversation, that we should be putting in a lot of focus on how to prevent this disease from ever developing. How do we change our food sources? How do
Yeah.
we get true intentional physical fitness back to our youth? How do we decrease screen time? How do we make the places where we live more accessible for biking and walking and movement? How do we encourage us to get up out of our screens? How do we do all of that? that's great. And that is part of our conversation of how do we
Sure.
fix systemic obesity. But it's very, very different than how do we treat the disease that we have right now, and that up to 50% of Americans will have by 2030. How do we fix that? And the GLP-1 medication is a very useful and viable tool for treating the disease, and we can't treat and prevent in the same way. So I just kind of also wanted to put that out in the ether. So if you're listening, remember, prevention is different and maintenance is different than treatment too. We need to do all of the things, but using a medication is not the easy way out. Your
Yeah.
journey has been very tough. Nothing about the journey has been easy. So
Yeah.
I'll get off my soapbox now.
No, that's a good one. And yeah, plus there's that maybe can address some of the physiological things around us or environment around us, but that doesn't address the psychological component that could have precipitated this, or even the genetic. I've read some studies on even your gut microbiome, or if you were born by cesarean, and depending on what's happening within, right? Okay, talk to that.
Yes.
Yeah.
I mean, I'm just like, yes, yes. It's so complex. Weight
Yes.
is so
Yeah.
complex. And epigenetics, I talk about this in the book, which I don't get, I get deep into the science in a way that's really relatable, but I think it's important for people to know that there have been fascinating twin studies.
Yeah.
And twins, you separate them, you put them in totally different environments, or you have a child who is adopted into a totally different environment. And there has been some fascinating work in Europe studying people for years and years and years, over generations, and you follow the biology of your genetics independent of your environment. And yes, we have changed the world and how we come to be, and even we have epigenetic imprinting on weight as early as in utero.
Yeah.
We talk about this in the book, but patients who lose weight in between pregnancies and significantly lose weight, children of subsequent pregnancies, the children who are born later, actually are thinner into adulthood.
Mm.
And so there is a room sometimes for potentially using these medications. Now we need to study this a little bit more,
Yeah.
but it's fascinating to know that it's just so much more. Like, I don't have control over what my mom ate or had. Like, she
Sure.
breastfed or she bottle fed me. Do I
Right.
prefer breastfeeding my kids? Yes, but like, I can't go back and undo that. You know, like,
Well, this is where empathy has to come in, but this is what we are void of, like this is where the girl in the TikTok just had none of that.
yeah.
And so I love this conversation so much, because I think that's what you're bringing back to our awareness, is that it's nuanced. There is a lot going on. It's not just, cut and dry one way, that people aren't exercising or eating properly, but there's so much that could potentially lead up to it. And now there is so much help available that we could potentially partake in. I do have one last question that I'd like to ask you about. I heard on a podcast with Dr. Tina Moore talking about microdosing GLP-1s, but not necessarily for weight specific issues, but for other issues. What do you think about that?
I have a lot of problems actually with this right now.
Okay.
My biggest problem is that when we talk about microdosing, often many of the people who are talking about microdosing on social media, as of 2 years ago, they were vilifying Ozempic. And this is a new way for them to take back ownership and control of the conversation, that they can do it better. And I think that there's just a lot of weight stigma and bias rooted in the conversation as I see it. And I think patients who often come to me saying, I just want a microdose. And I'll
Mm.
say, why? And they're like, well, I don't think I really need the medicine. Like, just give me a little. That's something we need to unwrap, right?
Right. Sure.
Again, that comes into this like moral superiority, like, I just need a little. I'm not like everybody else.
Right, right,
We
right.
need to
Or the
undo
goal
that.
is skinny, right? The goal is skinny. That's
Exactly.
the
And that
goal.
that is also right, true. And then we have to be careful that we still need to follow the science. I worry about using this medication to treat things that are subjective rather than objective right now, because that could lead us to a place where we are using this drug intermittently, unintentionally destroying our metabolisms because there is still potentially an element, even at smaller doses, that your body needs this hormone indefinitely. I worry that maybe there's more of a placebo effect with some of the lower doses. We have studied lower doses of these drugs in clinical trials. That's how the therapeutic doses get set. So I do think, though, we are going to be seeing so many more indications and uses. And I lay out the exciting future that I see in studies right now in the book. We talked about addiction. We talked about general inflammation, PCOS, dementia prevention. I think these things are coming. I just think we have to be careful about how we're using them right now before we have clinical validation. Otherwise, we might end up in a place where it's like, you get the drug and you get the drug and everybody's on the drug.
Someone's making a lot of money.
Yeah. So be careful,
Yeah.
still science, and I actually make a case for this in the book. We've had some bad history of weight loss drugs that have made a lot of people skeptical of weight loss drugs. Fen.
Yeah.
We talked through this. It has really changed the landscape of how clinical trials need to be performed. And GLP-1 medications have a very, very robust and long clinical trial profile. So they have been studied since the early 2000s, have been out for clinical use since 2005. And we look at it from every angle. I mean, we have large meta-analyses now of hundreds of thousands of people. And if we can't find that connection of overall health yet, I'm not ready to just start playing around with it in people one-on-one.
Yeah. Yeah. Well, that's good advice right there. I've loved this conversation. I love your passion for helping people. And I especially just love the well-rounded, holistic approach to looking at optimizing your health through diet, exercise, conversations, CBT, like all of that, I think is so, so important. It's exactly what we do at Move Daily Fitness as well. We do not compartmentalize just fitness and nutrition, say, here's a diet, here's a plan, good luck, go live your life. But it really, truly is about knowing thyself and exploring those deep parts of us that can cause addiction, that can cause us to get derailed from a target of optimizing health. And I really recommend Dr. Sowa's book, The Ozempic Revolution, and we'll have that available in the show notes, the link. So I think, that's a good book for anyone to read, not just someone who's planning on going on the medication. I will definitely be reading that just to increase my knowledge about even how to approach your nutrition, your diet in a healthier way. So thank you so much for your insight.
Thank you.
Yeah, it's been
This was a
great.
great conversation. I really appreciated it.
Oh, well, thank you. That's good. All right, folks, thanks for joining. As always, go Move Daily in your fitness, wellness, and nutrition, and we'll see you all in the next Move Daily Talks.